Okay, so this is just a little bit of a task, a little bit of a discussion, case study for you to all have a look at and just work through and just make your ideas, have a think about your options as you go along. What would you choose to do? What are your clinical options? Okay, so you've got a 30-year-old male who's had right leg pain for 8 months, getting worse recently. He's got numbness of the foot, and sometimes the pain's so bad that he's having to drag his leg. No urinary, no bowel symptoms. So, do they need a scan? What are your thoughts? What are your options here? What would you choose to do clinically? So, had a scan. These are the scan results here. So, looking at the scan, what can you see? What can you see based on each image here? So, you're looking at the discs, looking at the disc heights, looking for any protrusion into the spinal cord itself, looking at the quality of the images. Then you might go on to have a look at the disc itself, see whether or not there's any disc prolapse, having a look and seeing the angle at which the lumbar spine is sitting, and then thinking about looking down the spinal cord itself. So thinking about whether there's any disc protrusion that's going to affect the spinal cord as you sat into here, and looking at the quality of the spinal cord as well. Up onto here, you want to look at the normal curves of the spine. So as you can see here, looking at the lumbar spine here, you've lost that lumbar lordosis. So thinking about the normal natural curves. This would be more what you'd expect, say down into L5S1, thinking about that lumbar lordosis here, but that's quite a significant anterior pelvic tilt that you're getting through here, and then quite a flat lumbar lordosis higher up. So what impact does that have clinically when you're managing your patient? So this would have been reported as normal with the loss of the lumbar lordosis. So there's nothing there that you would want to do anything with. So if we actually look at the report, so preserved disc hydration and alignment, no inflammatory endplate changes or vertebral collapse, or spondylosis or foraminal stenosis. No evidence of significant disc prolapse or any neural impingement. So minimal central disc bulge at L4, L5 and L5 S1. So if we go back just to this one here, so looking here, so L5S1, you've got a slight disc bulge there, and then looking at L4, L5, slight disc bulge there, but then higher up you're looking at these being quite flat and there's nothing there, but nothing that's impacting the spinal cord itself. So the spinal cord itself is this darker ridge here as it comes down, but there's nothing that's impinging onto that spinal cord. No other focal active lumbar pathology or any sinister pathology. So at this point, do you go on and look for nerve conduction studies in view of the clinical findings that you found with your patient? And what do you tell your patient? Is your patient looking for an answer? If there's nothing appearing on the MRI scan at this point, how are you going to win them round in terms of diagnosis? What would be your advice? How soon after would you follow them up? And what would be your treatment plan? What I would like you to do at this point is just produce half a side of A4 about what your plan would be for this patient. What's your working diagnosis? What's your plan for follow-up? What would be your advice and how would you treat your patient? So I'd just like you to label half a side of A4 as patient A and have a think about advice, follow-up and treatment plan. Then on the other half of the side of A4, what I would like you to do is move on to this one. And this can be patient B. So you've got patient B who has a longer than 1 month history of lower back pain radiating into the right buttock and the right posterior thigh. The pain has now also started to radiate into the left lower abdomen. He's had it previously, but resolved itself. On examination, tender into upper and mid lumbar spine, normal tone, power and sensation, straight leg raise to 80 degrees left and right. Reflexes are brisk bilaterally with a few beats of clonus in the right ankle. So we're querying the pathology of the lumbar spine here. What pathologies are you querying at this point? So for patient B, have a think about what pathologies are you querying within the lumbar spine. So this would then be the MRI scan for your patient. So again, when you're looking down through your MRI scan, you're looking at the vertebral height and the quality of the vertebra. You're thinking about the disc heights. You're thinking, are there any disc bulges, so protruding? And if they are they protruding into the spinal cord itself? So again, you're looking at each sequence. You're looking for the quality, dehydration, so the amount of fluid that sits within the discs, and that's shown as the white within the disc. So the difference is down here, L4, L5, L5, S1. And again, looking at the sequence here, looking at the spinal cord, are there any compressive factors at L4, L5? And then L5, S1, can you see any compression within the spinal cord itself? So looking at the report for this one, L4, L5, there is a shallow disc bulge, mild bilateral facet joint arthropathy, no neural compromise. L5, S1, central and right paracentral disc protrusion with no neural compromise. There is no central canal or neural foraminal narrowing. There is no neural tissue compromise, and the visualized cord returns normal signal. And there are 5 lumbar type vertebrae with normal vertebral height, bone marrow signal, and vertebral body alignment, and the conus lies at L1. So your conclusion here would be mild degenerative change with no neural compromise. So that's the result of your report that you've sent off. Then what would be your plan? So what would be your plan here? What would be your follow-up plan? Would you then refer for nerve conduction studies? What would be your working diagnosis? What would you say to your patient? So on the second half of your A4 piece of paper, I want you to have a think about patient B. Maybe do it in the form of a spider diagram, just to have a think about what would you do here? What would you then refer on to? Would you refer on for any further tests? And this study here just talks about age-specific prevalence of degenerative spine imaging findings in asymptomatic patients. So if you look here, in 80-year-olds, you're looking at really quite high numbers of disc degeneration, disc signal loss, disc height loss, disc bulges. So 84% of those that you're going to image at age 80 are going to have issues with their discs. Looking sort of down towards age 30s, so half of those that we image will have disc degeneration. In terms of disc bulges, 40% will have disc bulges but be asymptomatic. Thinking about spondylolisthesis, there's definitely a trend where it goes up as we get older. And again, so you're finding that as the patient gets older, all of these numbers are increasing from left to right in terms of age. So when we're doing an MRI scan or we're doing an image, we're going to be expecting to find something. Even somebody that sits within their 20s, in terms of disc bulges, a third approximately will have disc bulges and disc protrusions, but they're asymptomatic. So that's not always the reason for them having the pain. So this is quite a nice visual in terms of what you would expect to find normally. And then these are the abnormalities found on scans in asymptomatic people. So as a systematic review, 3,110 studies looked at and found that disc degeneration, 37% in 20-year-olds and 96% in 80-year-olds. Thinking about knees here, so another systematic review found that in people aged over 40, between 19 and 43% would present with osteoarthritis on a scan, and then 4 to 14% under the age of 40. For a cartilage defect over the age of 40, 43% of scans would come back with a cartilage defect, and 11% under the age of 40. And then meniscal tears, 20% over the age of 40 will have a meniscal tear, and 4% under the age of 40 will have a meniscal tear. Again, these are all asymptomatic patients. Moving down to the foot, so thinking about those that have Morton's neuroma, so 54% were found to have Morton's neuroma when looking at a cross-section of patients with a mean age of 47. And then thinking about ATFL pathology, 37% were diagnosed with ATFL pathology Again, asymptomatic clinically, but when looking on MRI scan with a median age of 51, there was an ATLFL pathology diagnosed. Moving on up to the hips, looking at a systematic review of 2,114 in asymptomatic hips, 37% had a cam deformity, 67% had a pincer deformity, and 68% had a labral injury. Again, all asymptomatic. And then looking at the shoulder, 51 men were looked at aged 40 to 70, 22% had a partial rotator cuff tear, 78% had bursal thickening, and 96% had overall abnormality of the shoulder. Which raises the question, what weighting does this evidence have in terms of us referring for imaging, in terms of us clinically? And then looking up at disc bulges, age 20 to 70, 87% of asymptomatic spines had disc bulges. So what weighting does that give us? Are we just looking for something that will probably be there, that's not going to answer the question about why that patient has pain or why they present the way they do? This is a really nice table that shows post lumbar spine surgery, looking at only those studies that showed 300 patients or more, looks at the type of surgery that they've had and the outcomes and the complications. So if you have a spinal case study, it might be worth having a look at this table and sourcing the original literature, because that can add some weight into your studies and your pieces of work that you're doing for your summative assessment.